IPNA endorsed Webmaster Series 2020. It is a pleasure welcoming you all for this program. We have entered into webinar 21, and today we have got two eminent speakers, Dr. Bagga and Dr. Goldstein. Due to few technical issues, Dr. Goldstein is unable to join. He'll be joining us shortly. And so we are taking up the first talk with Dr. Bagga. Dr. Bagga is a professor, Department of Pediatrics at prestigious All India Institute of Medical Sciences, New Delhi, and his interest is towards glomerular disease. He is also a recipient of IPNA Educational Award in the year 2019. And 2017, he has received an award of Academy Oration by National Academy of Medical Sciences. And 2016, he has also received Nammalwar Oration by Indian Society of Pediatric Nephrology. And he has got n number of national and international publications. Over to Dr. Bagga, and he'll be talking to us on epidemiology of AKI. Over to Dr. Bagga.
Thank you, Dr. Ganesan. And can you see my slides now? Are the slides visible?
Yeah, your slides are very much visible.
Okay, thank you for organizing the IPNA webinar course, and I think it's been extremely educative for fellows and colleagues across the country as well as outside. What I'll be talking today is briefly about the epidemiology of acute kidney injury in childhood. This talk was supposed to follow Dr. Goldstein's talk, but he'll be joining shortly, so I'll probably begin and I'll just give you an overview of the causes of acute kidney injury in children. So acute kidney injury, Dr. Goldstein will be covering the various, how you define acute kidney injury. But essentially, acute kidney injury is a term that's being used now for the last few years in preference to acute renal failure. And there are standard definitions which we'll be discussing in the next talk. The importance is that acute kidney injury is a common illness that affects children as well as adults. I agree the proportion of children who are affected is clearly fewer compared to adults, but it's still a common disorder and there are serious sequelae. So what I'll be covering over the next few slides is that it's clearly an important condition. We know that acute kidney injury accounts for about 15 million patients a year, majority of which are in the developing world, and about 10% or 15% of these patients would finally die either due to end-stage kidney disease or due to complications of kidney failure. There is increasing recognition of acute kidney injury. The overall figures, in children are less compared to adults, but clearly even in children, it's a relatively, and as we will discuss today, it's a common disorder. Fortunately, the milder forms or stage 1 disease, which is just a transient or not really transient, but it's a minor elevation of creatinine and or oliguria, accounts for the very large majority of these patients, almost 70%. And the next 3 lines, really give you a summary of my talk here. The overall incidence of acute kidney injury is about 5 to 10% in hospitalized patients. So, especially, if you're working in a tertiary care center, you would have more acute kidney injury, and this is incident AKI. Incident AKI means there's that AKI that happens in a hospital setting and not somebody who walks in with kidney failure. Compared to this, in the ICUs, you have about 25 to 30% children in ICUs showing acute kidney injury at some point in time. The other important point to take home is that almost 1/3 to 1/2 of patients who are in ICUs with severe AKI, and severe AKI is AKI stage 2 or stage 3, would die, either due to AKI or due to other complications of their critical illness. But clearly, the presence of kidney injury is an important determinant of outcome. And finally, we know in adults as well as in children that about 20% or 25% patients who have severe AKI, again, severe AKI being AKI stage 2 and stage 3, would show chronic kidney disease on long-term follow-up. So clearly, there is a risk of getting sick with acute kidney injury, the risk of dying in ICUs, which is linked to kidney failure, as well as the risk of chronic kidney disease. Now, how common is acute kidney injury? And I would refer here to you to 2 meta-analysis involving large number of patients who were hospitalized. The first meta-analysis was published about 7 years ago, in CJSON, where they looked at almost 300 odd studies involving almost 50 million admissions in various hospitals across the world. And you can see this data from multiple countries across continents. And the proportion of incident AKI, again, incident AKI, mind you, is AKI that is happening after a patient comes inside the hospital, is almost to the tune of about 20%. In adults, and a similar figure in children. Now, you would realize that much of this would be based on the kind of hospitals that are providing this data, so there could be some degree of bias. But clearly, almost 20% to 30% of adults as well as children who are admitted would show presence of acute kidney injury, and there is a certain mortality associated with this acute kidney injury. The other meta-analysis again showed almost similar data, again showing incident AKI in about 20% of all patients, majority being stage 1, and a small proportion requiring dialysis, and obviously some patients were succumbing to the illness. Now, in order to precisely figure out, the overall how important was acute kidney injury as a cause of morbidity, the ISN did a 0 by 25 global snapshot study involving 10 weeks in 2014. So there was a large adult study, but in order to figure out precisely the burden of acute kidney injury in children, there was also a pediatric component. And as you can see here, there were studies done across various countries, and almost the whole world was represented here. Almost 90 centers across the world, 41 countries, done over 10 weeks. And what this study showed in children was that hospital-associated AKI was almost as common as community-associated AKI. So patients were either getting AKI in the hospital, or they were coming in with acute kidney injury, almost 50% each. Majority of this was mild AKI. However, 70% patients with AKI did show partial or complete recovery by day 7. They also tried to distinguish between the upper income countries, or the higher income countries, which is shown as HIC here, the upper middle countries, which is again, shown on this bar diagram, and the lower middle income countries. And what this data showed was that the highest mortality of AKI was happening in the lower and lower middle income countries, number one. Number two, a large proportion of AKI in the LMIC was due to problems in the community, so community associated. You often had stage 3 disease in these patients, and they had a high mortality. So clearly there is a burden of acute kidney injury in children, as is shown in this global snapshot study done about 5 years ago. Now, what's the etiology of acute kidney injury particularly across our country? And the slide and the matter in the left-hand corner, shows data from our hospital, again showing data over the last 4 decades or maybe 3 decades, showing that in the early 70s it was really acute gastroenteritis, minor infections, and acute glomerular nephritis that accounted for the large majority of acute kidney injury. It was not called AKI then; it was called acute renal failure then. But the chief causes are shown here. In the 80s and early 90s, HUS clearly was the chief cause of acute kidney injury in the admissions happening to the All India Institute of Medical Sciences. We still had a lot of glomerular nephritis. The diarrhea was already declining, because as a cause of AKI, chiefly because of better ORS and better hydration and so on. And over the years, diarrhea as a cause has gradually declined. HUS has continued to be stable. Again, HUS would depend a lot, on a referral bias. So hospitals like ours that take care of these patients, tend to see more. But what's become more important is that infections, particularly septicemia in an ICU setting, in a post-operative setting, is clearly an important cause of acute kidney injury. Acute glomerular nephritis is accounting for less and less patients who are getting admitted with acute kidney injury and so on. And on the right-hand side, you see data from Pondicherry, from JIPMER, wherein again the chief cause of acute kidney injury were infections, acute glomerular nephritis, and other causes. They had less hemolytic uremic syndrome. So data from Institute as well as Pondicherry, as well as from other centers in the country, do seem to suggest that the chief causes continue to be infectious illnesses and so on. Dr. Goldstein, I think, has some data on this, and I would not talk too much about this, but there is data from intensive care units across the world. And the AWARE study, which is the assessment of worldwide AKI, renal angina and epidemiology, was published about 3 years ago, involving about 5,000 odd patients from 30 PICUs across the world. The overall incidence of acute kidney injury in the AWARE study was to the tune of about 30%, and it's with a tight 95% confidence interval. Severe AKI accounted for about 40% of all AKI. So grade 2 and grade 3, stage 2 and stage 3, accounted for almost 1/8 of all patients in the ICU. And in patients who had severe AKI, there was a high risk of death, as is seen here. What is shown in the Kaplan-Meier on the right side is that the higher the grade of AKI, the worse is the outcome. So on the y-axis, you have outcome, patients surviving. So the best outcome was in the patients who did not have AKI. But if you had stage 1, stage 2, or stage 3 AKI, the outcomes were worse if you had a more severe form of acute kidney injury compared to the less severe forms. Again, this is a slide which could be repetitious with Stuart. He was supposed to speak first, and I was perhaps not. But then, there is data also regarding neonatal acute kidney injury, again published about 3 years back, involving multiple NICUs, including our country, India, Egypt, and other countries as well, which accounted for almost 2,000 odd neonatal patients who were critically ill. And acute kidney injury was defined in a very standard way. And we'll be discussing this in the main talk that Stuart will take. A rise of creatinine or reduction of urine output. This is kind of more specific for newborns. And in these neonatal ICU patients, again, almost one third or 30% had acute kidney injury. And patients who had acute kidney injury had a higher risk of mortality and a longer hospital stay compared to the ones who did not have AKI, which again is shown in the Kaplan-Meier on the right side. So both in ICUs, neonatal as well as pediatric ICUs, AKI would account for almost, as I said, about 1/3 of all admissions and would be directly linked to mortality in ways, that could be linked to the renal failure, but also due to other causes. This is an interesting paper, an interesting review in which Dr. Goldstein is also an author, in which they discuss the global epidemiology and outcomes of acute kidney injury across the world. And if you just look at the pediatric data, if you look at critically ill, so this is really data from multiple cohorts, again, supporting what we've just said. So almost 1 in 4 pediatric patients would show acute kidney injury in the ICU. A proportion of them would require renal replacement therapy, and about 10% of these patients would finally succumb to their illness in the intensive care. The risk of getting acute kidney injury is much higher in especially the post-cardiac surgery patients, where the risk is to the tune of almost 1 in 3 to 1 in 2 patients. The outcomes are generally better compared to the ones who are critically ill in ICUs otherwise. And overall, the dictum, and if you look at this small box in the bottom, if you look at AKI in the developed countries, AKI chiefly has been seen in older patients and older adults in a setting of multi-organ failure, septicemia, that happens chiefly in ICU settings, post-op and so on, and they have a high mortality. Compared to the developing countries, where AKI is a problem mainly of the young, including children, very often it's a single disorder like, say, gastroenteritis or malaria or leptospirosis or so on, and obviously because you've got a single disease and you don't have multi-organ failure, the outcomes are comparatively better. I must say, however, and I'm sure that that's the experience with most of you across various across centers in our country as well, as we have more sicker and sicker patients in the ICUs, our patients would often, behave like patients that are seen in the developed world, so you have much more post-surgery acute kidney injury, post-cardiac surgery acute kidney injury, multi-organ failure, and so on. So clearly, the differences seem to be diminishing. However, there are some broad differences in the developed and the developing countries. And this is, one study again saying the same thing, on say 500 odd patients admitted to a hospital about almost a decade now. It's published in 2012. So we had about 500 patients. About 5% of all these patients had acute kidney injury at admission. So this is patients who come with AKI. So we excluded them. Then we looked at patients who did not have AKI. And of the 486 patients that we had, there were about 100 who were critically ill, and there were 378 that were not critically ill. And the overall incidence of acute kidney injury in the not critically ill was about 10%. Again, saying the same thing that I just said. So the incident AKI, or the AKI that happens in the hospital setting, is almost to the tune of about 30% in the critically sick and about 10% in the non-critically sick patients. Again, for a hospital like ours, that is, again, a tertiary care center, so a lot of non-critically ill patients are patients with malignancies and so on. So clearly this figure may seem a bit high compared to somebody who's working at a primary center or say a district hospital. But even there, one would expect about 5% of all patients to get incident AKI in the hospital setting. Over the next 2 or 3 slides, I talk to you about some tropical diseases. Again, this talk was supposed to follow the main talk. So I did not talk about the major conditions here. But particularly in North India, we have, and I'm sure even in Chennai, even in other parts of the country, you would have these tropical infections. Malaria is a common disorder which is there, hyperendemic in many parts of the world. The risk of AKI is about 1 to 5% in malaria. But in severe malaria, the risk may go up to as high as 50 to 60%. And the usual kidney biopsy, if you were to look at the kidney histology, what you get on kidney histology is either acute tubular necrosis, rarely interstitial nephritis, or a GN. Black water fever is fortunately less common here now, but again, black water fever would have hemolysis and so on, and the patients would typically on the kidney biopsy show acute tubular necrosis. But what we seem to be seeing a lot in North India at least is the occurrence of thrombotic microangiopathy that follows P. vivax infection. And we have been having, these spurts of TMA secondary to Plasmodium. The other important tropical infection, which I'm sure that you also are seeing across the whole country, is dengue. And again, fortunately, the risk of AKI is 0.3 to 5%. And happens more often in dengue hemorrhagic fever stage 4, presents chiefly as an oliguric AKI, and you have the standard kidney histologies. Leptospirosis is unique to certain parts of the country. It's not there and unique to certain seasons. Presents chiefly as a non-oliguric AKI, and so with the transaminitis, with renal failure. And on histology, you could get either tubular necrosis or a mesangial-proliferative GN. 2 other important groups, that I thought I will discuss, because I know Stuart will be discussing about nephrotoxic injury. I thought just to kind of complete the picture, especially from a tropical perspective, we do see snake bites as a cause of renal failure. Now, these are usually the vipers. Sea snakes is not the problem, at least in North India, but vipers in particular, they could cause a very severe kind of renal injury due to hemolysis, hemoglobinuria, and you typically get acute tubular necrosis, although other conditions could also happen. Interstitial nephritis, and the therapy is chiefly supportive apart from antivenom administration. Now, at times, we have seen acute kidney injury in young children following stings, the wasp or the hornet. We have more wasps than hornet, but there are reports across Asia, and we have seen children even in North India, in Delhi, who have come, particularly young children who cannot run away so rapidly, and they get bitten by hundreds of wasps, and they end up getting acute renal failure. The therapy again is chiefly supportive, with managing them with renal replacement therapy and so on. And so again, that's a problem that's kind of unique, at least to the tropics. And another problem, which is a nephrotoxin injury, is the use of diethylene glycol. Do you know that diethylene glycol has often been used as a contaminant for a number of syrups, particularly paracetamol, some cough syrups instead of using glycerine because it's much more cheaper. And diethylene glycol poisoning presents typically as an acute kidney injury, cortical necrosis with severe renal failure, and they have severe neurological sequelae and high mortality. The first reports of diethylene glycol associated AKI came from Bangladesh. And in late 90s, there were reports from North India, particularly Gurgaon, later from the All India Institute as well, where, it was an important thing. So keep this in mind that diethylene glycol can be used by industry or by pharmaceutical industries instead of glycerine, and very often, it's used as in paracetamol and various cough syrups. This can really cause severe injury. We are, living in difficult times, and an important question that's often asked is that can COVID also cause acute kidney injury? I'm sure you must be remembering the advertisements that were coming initially, when COVID was just beginning in India. And the ad did say, that kidney failure could happen. And we'll talk about this in the next slide. But kidney injury could happen due to COVID, due to certain direct effects. Like, you could get a direct effect of the coronavirus on the glomerulus, causing a collapsing glomerulopathy, endothelial damage, and so on, complement activation, and so on. But in addition, you could have various problems that happen due to the coronavirus infection per se. So you could have hypotension, you could have hypervolemia, you could have nephrotoxin injury due to drugs that are being used. The organ crosstalk that happens, because of lung injury. So you have a pulmonary renal crosstalk, and other things. They could all further perpetuate the kidney injury. And there's an excellent article, in Nature Review Nephrology, which is open access, that talks about COVID-19 associated AKI, published just last month, and how you would be managing these patients, monitoring for acute kidney injury, and then, just providing standard management as well as renal replacement. What is the extent of AKI in COVID? And, I'm just kind of showing you some data here, but you could perhaps just focus on this meta-analysis of 140 odd reports involving about 50,000 patients, showing that almost 20% or 28% of COVID in hospital in US and Europe could have acute kidney injury of varying severity. The risk is perhaps slightly lower in China, where the figure reported is something like 5%. So clearly, the risk would depend a lot on the kind of patients that you are admitting, but these are essentially hospitalized patients. So about 20% inpatients could get acute kidney injury in COVID. And if you look at the ICU patients, about 1/2 of all ICU patients could get COVID. In children, if you look at the multi-system inflammatory syndrome, COVID causing AKI would happen in about 12% of all children. So it's an uncommon presentation. We know that multi-system inflammatory syndrome is also uncommon, but this is a good meta-analysis that has looked at the association of AKI in the MISC in children.
I wanted to discuss that the risk that while acute kidney injury can cause problems acutely, there are major risks that pediatricians should be aware of on the long term. And there is data to show that while, as is seen in the picture on the left-hand side, while the majority of patients, children as well as adults, would get well after an episode of AKI, as shown in the light green line, the horizontal line on the top, there could be a certain proportion of patients who would go on to end-stage kidney disease, as is shown in the line below, the red line below, and they would either die or they would be on chronic dialysis. But there would be a proportion of patients who would show a slowly progressive injury, and this would gradually progress to chronic kidney disease. And there is data from our country as well, and there was if I recollect, there was a paper about 7 years ago from Calcutta by Rajiv Sinha and other colleagues, where they showed that the risk of chronic kidney disease was substantial in patients who were recovering from acute kidney injury. So based on data from various reports as well as data from across the world, the KDIGO currently advises that patients who are recovering after an episode of AKI should be followed up. They should be first reviewed 1 month after discharge, and then sequentially over the next 2 years to be looking for evidence of chronic kidney disease, chiefly in terms of proteinuria, hypertension, and perhaps at least doing a serum creatinine level on multiple occasions. Next slide. This is again, repeating what I just said, that and this is again is a large systematic review on 13 large case studies showing that the incidence of CKD was to the tune of about 25 per 100 person years. So clearly the risk is significant. A proportion of patients may show end-stage kidney disease and so on. And there are prospective studies that are happening currently looking at the risks of chronic kidney disease, the ASSESS AKI study as well as the ERID study, which is looking at the risk of acute kidney injury progressing to CKD. Next slide. This was really, the last slide of the supposedly brief presentation that has become a long presentation regarding, that AKI is common. It's an important cause of death in a hospital setting. And the International Society of Nephrology, along with other sister societies, has resolved that by 2025, we should not have patients dying of acute kidney injury. So you should not have patients dying of hyperkalemia or fluid overload and so on. So you could still die with acute kidney injury, because of other complications. But clearly there is a lot of emphasis, interest and action being taken to be able to provide renal replacement and supportive care so that by 2025, the mortality due to acute kidney injury is brought down to zero. We don't know whether this will finally happen or not, but there is clearly a lot of effort happening here. So I'll stop here. I'm happy to take questions. I may not be able to read the chat very well, so you'll have to probably read out the questions, Dr. Ganesan. Thank you.
Thank you so much, sir. It was an excellent insight of the whole talk. And so, little unfortunate that Dr. Goldstein is unable to join because of the connectivity issues, but still we'll take up the questions for Dr. Bagga. So can I read out the questions for you?
Yes, please do.
So, the first question is how to suspect DEG poisoning?
Yeah, tough to suspect, unless it's happening in multiple patients. But I would imagine, in any child who presents with acute kidney injury with very marked neurological symptoms, keep this in mind, The other differential in these patients, so obviously if you've got very marked irritability, coma and so on, you would think about things like Shigella encephalopathy, you'll think about HUS, Shigella associated HUS, azotemia and so on. The presence of crystals, particularly oxalate crystals in the urine could suggest an underlying DEG poisoning. But again, very often the kids are enduric and they have bad renal failure. But the renal failure at times, becomes better. But the neurological sequelae, oxalate crystals in the urine would clearly be something that one would be worried about, But I think DEG poisoning would be a rare diagnosis. I brought it up chiefly because I thought I had expected that Stuart will be covering the whole of nephrotoxic, So it was just trying to highlight a specific form of injury.
Okay, so the next question is AKI in HRS in children versus adult outcomes.
AKI in?
HRS, it's just the abbreviation he has meant. I'm not able to find out what he has written.
Syndrome, perhaps. So, so in hepatorenal syndrome, obviously hepatorenal syndrome could happen both in a setting of, I think the question is hepatorenal syndrome. So acute kidney injury could happen both in acute as well as in chronic disease. It's chiefly a vascular issue. So if one is able to manage the liver disease, very often, the only definitive way I would imagine would be a liver transplant. There are drugs that have been used, and I won't be able to tell you the exact protocols here, but there have been agents that have been used. But I think overall, the final therapy for HRS would be a liver transplant, particularly if it's a fulminant hepatic failure or a very bad liver disease, because there's nothing inherently wrong with the kidneys per se. So you would think about some therapeutic interventions, but chiefly, a liver transplant. Next question, Kalaivani. I'm not very good on HRS, so. question is not the best
Okay.
answer, Yeah.
The next question is criteria of urine output is 0.5 ml per kg. Is it in low birth weight or actual weight?
Is it the ideal body weight or the actual weight? How does it matter? Don't go into
Ideal,
such
yeah,
nitty.
ideal body weight or
It
actual
doesn't,
body weight?
it doesn't matter. So it's the actual body weight. It cannot be the ideal body weight. So it is the actual body weight. Now you can always ask, suppose somebody has got fluid overload, then what weight? How does it matter? So it's the weight of the child. So it's 0.5. But remember that for newborns, it is 1 ml per kg per hour. And so it's 0.5 mils per kg per hour for stage 1, lasting for I think 6 hours. Then for stage 2, there's another cutoff, and for stage 3, it's less than 0.3 or anuria. So depending on the severity of oliguria, you would grade, but it's the actual weight, if that was the question. Next question.
Okay, fine. Thank you, sir. The next question is fluorosis as nephrotoxic agent in children. Will you be able to elaborate upon?
Yeah, I don't know whether I can answer this very well, but fluoride, people have looked at fluorosis in multiple ways. The first time, at least we started looking at fluoride was when fluoride can, just let me plan the answer, So, so fluoride is a tubular toxin, in many ways a tubular toxin. So it can cause a picture like renal tubular acidosis in severe, chiefly by affecting the mitochondria. And there was a recent thesis at the institute wherein they were looking at the electron microscopy of fluorosis in the kidney in relation to the kidney. And they found, that there was severe mitochondrial damage happening due to fluorosis. So chiefly a tubular toxin. I don't know whether it can cause glomerular damage also or not, because that thesis did show, that there was some glomerular injury, but it was chiefly a tubular injury and affecting the mitochondria. But it's a tubular toxin. I hope it answers the question,
I think you have clearly answered. And the next question is, in a case of acute kidney injury in nephrotic syndrome, do you need to adjust creatinine for albumin levels? Also, how do we adjust creatinine level to fluid overload?
So in case of acute kidney injury in nephrotic syndrome, do you need to adjust creatinine for albumin level? How do you adjust for albumin level?
It's like usually they calculate calcium for albumin level. I don't know, like creatinine for albumin level is being asked.
I don't know. I don't know the answer. And you can adjust creatinine level to fluid overload. You can adjust, and I think it's a good question because it's often said that when you have fluid overload, imagine somebody having a fluid overload of 20%. So the creatinine level that you are getting is really a underestimate, because the creatinine is also getting distributed in the extracellular fluid volume and so on. So in patients with fluid overload, ideally one should adjust based on the fluid overload level. And there's a simple formula, and but it can be adjusted to the fluid overload to be able to classify this better. Having said that, practically speaking, you hardly ever need to do it. If you really have significant fluid overload, you are clearly in AKI stage 2 or 3. And I don't really think that it matters very much, whether you are in AKI stage 3, because very often you're in AKI stage 3, and you require dialysis. So it's something, that's more theoretical, but clearly it's possible to adjust creatinine to the fluid overload based on the extent of fluid overload. I don't know the answer to the first part. How do you adjust creatinine to the albumin level? I have no answer to this.
Okay, fine, sir. And the next question is, in critical care, how to do staging of AKI at presentation?
So how to do staging at presentation? So the various, I'm not expert on AKI, and clearly for this talk, it was an unprepared thing. But what I do know, that at presentation, the 2 or 3 indices, obviously you can use biomarkers, but the 2 indices, that have been used increasingly now, one is the renal angina index. And there have been studies, and that is chiefly based on the level of on the serum creatinine and the fluid, and I think it's the urine output. I'm not sure really. So it's the underlying disorder.
Yeah.
You're getting admitted to an ICU, whether you are post-transplant and so on. In addition, to the baseline serum. The second thing is the serum creatinine. Is the third is the fluid overload. I think these three things are accounted for in the renal angina index. And if you have a RAI that is more than 8 or more than 12 in various studies, then the likelihood of getting severe AKI over the next 12 hours or 24 hours is clearly high. So the renal angina index works well, and there was a paper from our center also. We were trying to look at the exact cutoff, and I think the cutoff that we got was 8 and 12. So both were performing as well. So you can do a renal angina index at presentation that could predict the likelihood of acute severe AKI in the next 24 hours. The other index, that is being considered important is the furosemide stress test, in which we all know that as pediatricians we often give furosemide for inducing diuresis in a patient who has oliguria. So if you have a patient who has oliguria who has not been given furosemide before, if you were to give him furosemide now and see what the urine output is over the next, say, 6 hours or 8 hours, that again is a good marker of the level of kidney injury. So both the furosemide stress test as well as the renal angina index are likely to predict severe AKI in patients at presentation to the ICU. I hope I've answered your question well, but these are the two indices that we have used. We don't use biomarkers because I think they don't help very much, but we have chiefly relied on these biomarkers, which are also biomarkers in many ways. Okay, next question.
The next question is, as per data, there is a decreasing in incidence of glomerulonephritis as cause of AKI. Any specific reason, sir?
I think it's better treatment of, so it's not the GN per se, it's the acute post-infectious GN. So I think clearly there is a better management of infections like sore throat, pyoderma, and so on. So clearly, I think as a proportion of patients, when I joined the institute as a undergraduate and as an MP, and I would often look through the files, of 70s. I didn't join in 70s, so I'm kind of younger than that, So don't imagine that I joined in 90. So when I was looking at the files of 70s, there were so many AGNs coming to the hospital. Currently, we have no AGNs that come to the hospital. I think they are either managed well in the periphery, and again, better management of sore throat, pyoderma, and so on. I think that's the reason why the infection-related GN has declined over the years. It could still be there. Now, the other thing that has changed is that instead of strep, you have other infections. So you have staph, for example, particularly in the developed world. You also have, so instead of sore throat, you now have other things, that you have various shunt infections. You may have something else, happening in various prostheses that are implanted. So that's chiefly happening in a more chronic manner. Staph more than strep. Interestingly, staph, so the non-strep infections are clearly much more sinister. They are much more chronic, and they have much more sequelae than the typical PSGN or the post-streptococcal GN that we used to see years ago. Okay, next question.
Okay. The next question is, how aggressively do we need to consider hyperuricemia in any AKI? When do we decide on to treat?
So other than tumor lysis syndrome, where we would consider it as a marker of tumor lysis, we do not take action on hyperuricemia. I'm giving this as a blanket, as a overall arching statement. Now there are some caveats. Now, number one, I've seen that most patients who present to us with AKI, with anguria, would often have uric acids like 12 or 13. I don't think they are such a big issue, and we would never dialyze, but because they're anuric, they are getting hemodialyzed, and the levels would, I assume that the levels would decline as you dialyze these patients. But I have never dialyzed a patient with acute kidney injury for hyperuricemia. Now, if this would happen, say, in a setting of tumor lysis, even if so one would perhaps think that this patient is likely to go into problems later, and one would dialyze them earlier. For tumor lysis, you also have this new drug, whatever that drug is, which is a drug that the urate oxidase inhibitor or whatever.
Allopurinol and rasburicase.
Not rasburicase, So rasburicase
Rasburicase.
has also been used, for AKI, for tumor lysis in order to reduce uric acid. And there are reports that rasburicase acts as well. But outside tumor lysis, rasburicase would have limited role. But so I normally would not get too much hassled at sepsis-induced AKI or HUS with a high uric acid level. So we do not treat most patients with in the setting of AKI for uric acid hyperglycemia.
And the next question is usefulness of diuretics like torsemide over furosemide in oliguric pediatric patients.
I only thought that the advantage of torsemide is that it's got a better bioavailability. I did not know that torsemide is a more potent diuretic than furosemide. So I think there is no usefulness of diuretics like torsemide over furosemide in oliguric pediatric patients. That is one. In nephrotic syndrome, it has a better absorption through the gut. So perhaps it is better, but again, even there the data is weak. This is one. Number two, I would not use diuretic. The role of diuretics for oliguric AKI is overall limited. If you have a patient who is enuric or oliguric, there is no data that shows that using furosemide, high dose or infusion, leads to better outcomes. The only benefit you get is that you can prevent or delay RRT for a few hours. So the current KDIGO guidelines also say that if you have a patient who is in fluid overload, and while he is awaiting dialysis, you can use high dose furosemide to induce some diuresis. But there is no data that I know of that shows that the use of furosemide or other loop diuretics would improve mortality per se, or would lead to better outcomes in acute kidney injury. And this is not one study, these are multiple studies, both in children as well as in adults. There have been Cochrane meta-analysis on this. So I would definitely, not want to give an impression that in a patient who is fluid overloaded, one should use furosemide over renal replacement therapy. This child requires renal replacement, he should be provided renal replacement. And I'm sure Dr. Goldstein would have said the same, and he would also have highlighted in his talk, and I'm sure the slides are there, that any fluid overload that is beyond 10% requires RRT. And fluid overload you calculate in a very standard way. So any child who has, because one of the chief predictor of outcome in AKI is fluid overload. And the way to manage fluid overload would to provide RRT. Furosemide or torsemide could provide short-term benefits, but they cannot be relied upon to improve outcomes.
Okay, fine, sir. And the next question is how to adjust drug dosages of antibiotics in critically ill children.
Okay, so you would have to use standard charts. Now the question is that the charts would show and so you will always have to look into your tables. You have GFRs below 10, GFR from I think 10 to 50, and more than 50 for most drugs, And suppose you have a child who is enuric, assume that the GFR is below 10. At times the problem that happens is that you may have a creatinine that is not in the less than 10 GFR range, because the creatinine does take a couple of days or say a week to rise. So if somebody is enuric, you have to assume that the kidney function is 0, and you would have to then dose the drugs based on the GFR below 10. Okay, and so on, Once the AKI is settled, then you would again dose based on once you have a creatinine value and the child is passing urine and so on. So you would have to use tables. There is no other shortcut, there are no formulae per se. Some drugs require reduction of dosage. Most drugs require both reduction of dosage as well as increase of duration. But then, these are going to be specific for each drug. There are very few drugs that do not require any modification. And one should be aware of those drugs. But again, those drugs are few. For most drugs, one has to modify the dosage and or the duration. Okay.
Okay, and the next question is, what is the current consensus for contrast-induced AKI? Is there a role of N-acetylcysteine or soda bicarbonate, or only saline hydration pre and post contrast would help to prevent contrast-induced nephropathy?
So all your points, that the ones that you have mentioned have all been looked at. So N-acetylcysteine, soda bicarb, hydration, pre and post contrast study. So they all have a role. The important points are obviously hydration. There is no evidence based on the last study, which was, I'm sorry, can you hear me? I'm not.
Yeah, I am able to hear you, sir.
So the last large study, I'm forgetting its name, had looked at saline versus soda bicarb, and had also looked at N-acetylcysteine versus a no N-acetylcysteine. What that study showed was that it's only saline hydration that's important, which could be oral, which could be IV. Having said that, KDIGO still recommends the use of N-acetylcysteine, 600 mg twice a day for 2 days prior to the procedure. There is limited role or no role of doing hemodialysis post-procedure. However, the important point is that one has to use the amount of contrast should be the minimum. We use a low osmolarity contrast. So use a low osmolarity contrast, minimum contrast, and ensure hydration. I don't think there is data. The last study, I'm forgetting its name, did not show a benefit of soda bicarb over saline hydration. Now, is there any role once AKI is settled? I think so. There's one study, last year that came that said that perhaps, at least in children, contrast nephropathy has been overhyped. So keep your mind open. That study showed that while it's there is a slight rise. The way they define contrast nephropathy, if you look at the papers, they'd say any rise of more than 0.3 or 50%, that is stage 1 AKI, is thought to be contrast nephropathy. That paper, which came last year, I'm forgetting the paper, but chiefly because I was not prepared for this talk, so I'm just kind of taking Dr.
I
Goldstein's
completely
questions.
understand, sir. I'm sorry about it. I had to make you answer all the questions.
But I'm happy to answer. So that study showed, that at least in pediatrics, this contrast nephropathy is an overhyped thing, So keep your mind extremely open. Adults, may it's important, jahan pe or multiple issues are there in a setting of, say, MI and so on, and where large amounts of contrast are used. So I think as long as you use small amounts of contrast and you use low osmolarity contrast, I think it's okay, and hydration. And once you have AKI, it doesn't matter. Role of Lasix we have talked about, so clearly no role, I think the message should be quite clear. Renal angina will
It's
predict
already been discussed. Next is
yeah.
renal angina will predict the probability how to stage already in the set of AKI. I think you have already discussed about it, sir. Do you need anything to add on, sir?
How to stage already set in AKI. But we should be able to stage AKI, because that the way you stage AKI is by standard criteria of urine output and serum creatinine. So I don't need to go into the staging here, but it's a very standard sort of staging, unless I'm missing some important part of a question, that you are asking, but I don't know, anything, but the staging is relatively simple. It's stage 1, stage 2, stage 3, based on the level of urine output and serum creatinine. There is more and more data that says, I'll just have two messages here. There is more and more data that says that urine output always should be looked at. In our hospitals, urine output is often not checked well. And whenever urine output is checked, there is data that it's a better predictor than the serum creatinine. That's one, because it often serum creatinine would take a while to rise. And number two, in stage 1 AKI, particularly the people who are nephrologists here, you'd know that stage 1 has either a rise of 0.3 milligram per deciliter over 48 hours or a 50% rise over 7 days. So there are two parts to stage 1. So either a rise of 0.3 milligram per deciliter of serum creatinine that happens over 48 hours, or a 50% rise that happens over 7 days. And people have tried to classify this into 1A and 1B. The 1A is the 0.3 wala. So there has been one study, on about 5,000 odd adults that showed that 1A has a better outcome than 1B. So 50% rise is perhaps worse than a 0.3 milligram creatinine rise that happens in 48 hours. But again, these are fresh things, has to kind of, these are one single study, although involving a large number of patients. But people have even tried to define stage 1A and 1B. But the important thing is to be worried about stage 2 and 3. I think 1A, 1B, anybody is not such a big issue, Stage 2 and 3 is, and the only thing that's happened new, at least in the last 1 year, or maybe not 2 years, maybe even more than 2 years, have been 3 or 4 trials. One was the Akiki trial, the AKI, the Elaine trial, and now the Start AKI trial. Now, all these 3 trials were looking at when to start renal replacement therapy in acute kidney injury. I know I'm digressing a bit. And data from all these 3 trials, even individual patient data, seems to say that in a patient who has acute complications, you have to do the dialysis anyway, But suppose somebody does not have complications, suppose somebody has stage 3 AKI with a high urea, but no complications, there's no need for doing an urgent dialysis without, one can very easily wait for a while. I hope the message is clear, so there's no need for a very early dialysis. There's no data based on these 3 studies to say that early dialysis helps. However, if somebody has fluid overload, somebody has hyperkalemia, hyponatremia, whatever, severe hypertension, you have to dialyze those patients anyway. So staging is not, I don't think it's a very tough thing, so I would not worry too much about staging. Okay. It should be feasible. I hope I'm getting the question right.
Yeah,
So
yes,
seeing
sir.
lots of,
And the next question. Yeah, seeing lots of children below 1 year with nephrotic syndrome at admission needing RRT during COVID, but negative for COVID. I think it's more of like a comment as well.
Tough to answer. Yeah. I don't know the answer, but uh, uh, I was just seeing our data today morning. It just happened. We've had a few patients, but not too many. I don't think it's increased. My own feeling is it's not increased. Our overall feeling was perhaps no. But maybe it's just poor. Yeah, I think maybe these are patients with FSGS or whatever. But sorry, I can't add more to what you've written.
Okay, fine, sir. And the next question is place of acute peritoneal dialysis in pediatric ICU today, alongside the pediatric CRRT, your preference?
Uh, Dr. Rajan, sir, so if the child is hemodynamically stable, we are happy doing chemo or SLED or something, in a hemodynamically unstable child, obviously, though, you have choices of either doing acute PD or pediatric or CRRT. CRRT is, if feasible sites, clearly it would be better. Acute PD has its own issues, at times in patients who are in shock, the clearance, etc., may not be as good. So we would still prefer to do CRRT in somebody who is hemodynamically compromised instead of an acute PD. But suppose suppose CRRT is not possible at all because of very low blood pressures, being on 4 inotropes, and other complications, then we still at times do acute PD in an ICU setting. We are increasingly, just like other colleagues across the country, using more and more SLED for our patients who are, but then SLED would again work with moderate hemodynamic instability. If there is severe hemodynamic instability, it's going to be either CRRT or PD, but then PD at times may not work as well in patients whose blood pressure is virtually unrecordable, because you would have very poor peritoneal flow and so on. I hope I've answered your question to some extent. Yeah.
Yes, sir. And the next question is the role of metolazone in loop diuretic resistance.
For nephrotic syndrome, it's fine, but not for AKI. So for nephrotic syndrome, there is no doubt, that thiazides per se, they would work at a different site, and we would definitely advocate, and we happen to be coming out with our revised guidelines on steroid sensitive nephrotic syndrome as well as steroid resistance. So I totally agree with you, where patients are not doing very well with furosemide. There is definitely a role of using thiazides. Metolazone is a more potent diuretic because it also acts on the proximal tubule, but one could also use hydrochlorothiazide in patients who are showing apparent loop diuretic resistance.
Okay. And the next question is really by experience, furosemide infusion in AKI has good effect. Yes, there is no evidence. I think it's more like.
So my comment to this is that I agree that when you are going to infuse furosemide, there will be some urine output. I'm not contesting that. The question is, does it lead to better survival on the long term? And the way you can answer this is only through good quality randomized controlled trials with minimum bias. So you have a double-blind placebo-controlled trial wherein you are giving furosemide to one group and you're giving a sham injection to the other group. Otherwise there's always going to be bias. And people have not shown better survival. So while the urine output may improve, the quality of urine is not going to change. You still have, so you would still not be able to pass out, for example, say creatinine or urea and so on. So you just can't discount studies that are, and not one study. In fact, if you really ask me, there's not even a single study that says that furosemide has any benefit in terms of recovery of kidney function or in terms of mortality. I agree definitely with you that when you give furosemide, there would be some diuresis. And I also know, that there is this constant dilemma, and I have no problem using furosemide on the short term, but using furosemide as an alternate to dialysis is perhaps not a good idea.
Okay. And the next is it is appreciation. It's been always great to hear from you, Prof. Followed by a question. AKI progress to CKD rather than the primary cause and the patient's comorbidities and their specific factors, which can predict that AKI can progress to CKD. How long we should follow up for CKD development from AKI to CKD?
So I'll answer the last part first. The current KDIGO guidelines say follow up for 2 years. I think I'm sure there are risk factors. There is just today morning, I saw a review article posted on the PGI NEF-SERV list from the CKJ, the Clinical Kidney Journal. It's excellent. In fact, I was trying to include that slide, but could not. Today morning, there's a review of the risk of chronic kidney disease following AKI. I've not read the article because it just came today morning, but it's a good article to read. I'm sure there would be some risk factors, but again, the severity of AKI would be the most important risk factor. So somebody who has had stage 2, stage 3 AKI, somebody who shows bad histology on kidney biopsy, those patients are clearly going to be at risk. So there would be risk factors. I'm sure there are. For example, AKI stage 1 would not be an issue. Newborns, for example, are at a very high risk. It's thought that almost 20% newborns would be because the neonatal kidney injury is perhaps happening at a time when the kidney is rapidly maturing. So newborns particularly are at high risk. So pediatricians particularly, should be following up, and I would imagine at least doing urine protein, checking blood pressures, doing serum creatinine for at least, a year at the minimum, So you can see the patient, as KDIGO says, call them at 1 month, then quarterly for at least a year, and then maybe annually, and keep them on some follow-up. Don't just let them go.
Okay, fine, sir. And so the last question is IV albumin per se in presence of oliguric AKI is nephrotoxic or is avoided just due to the risk of pulmonary edema in edematous patient with hypoalbuminemia?
I think the latter. I don't think there is data that IV albumin per se is nephrotoxic. It's a isoosmolar solution, so it's not nephrotoxic. It's the risk of pulmonary edema or fluid overload. So if you've got an edematous patient with hypoalbuminemia and oliguria, I think it's really fluid overload that you're worried about.
Okay.
Okay.
I think we have answered all the questions, sir. Thank you so much, sir, for the enlightening question and answer session. We have almost come to the end of the time. It's almost 8:50. I think you have made the session completely yours, sir. It was a great talking to you and it was an enlightening session per se. Thank you so much, sir. Probably sorry, Dr. Goldstein, sir. Yeah, sir.
Sorry, Kalaivani, sorry. What are you saying?
Dr. Goldstein was unable to join because of the connectivity issue, but he has promised that he'll be giving the session separately in his convenient time sooner. So probably we'll wait for his talk soon. But it was such an enlightening talk, sir. You had really made the day and the whole session yours. Thank you so much, sir.
Thank you, Dr. Ganesan. Thank you very much.
Thank you so much, sir. Thank you, sir.